This is Jerry Hesch with a very interesting case. And this client delivered a very large baby, a 10-pound baby, and had symptoms ever since. She also had several falls. She did undergo standing pubic x-rays in the recent past, and they did demonstrate 2 to 3 millimeters of vertical movement. I'm intrigued by the amount of width here, and you do see little osteophyte formation, so the joint is trying to stabilize itself, and the measurement at the mid joint is in my opinion of considerable width. And you will see that on the table when we test the width of her pubic structure, it's even more than what you see on x-ray. Realize the pubic joints are curved inward. The bones are curved inward. So let's go ahead and have you get on the table and show that, please. So we're only going to film the pelvic part, so we're not going to identify the client. And I'll put some lights on. Go ahead and line your back. When I started to palpate her structure, I was immediately struck by the width of her pubic bones, how wide they are proportional to her body. And when I come on the very top, there is a step down just like you see on the x-ray, and when you go right to left, you do climb up. But the pubic bones have a distinct width, and you can see that I can fall into that depression where the fibrocartilage is. So the other thing is that looking at front to back on the pubic bones, they are out here, and when she looks symmetrical top to bottom, but when I put my finger into where the fibrocartilage is, and I'm pushing somewhat firmly, I'm certainly pushing with at least 5, maybe 10 pounds of force. Look at the width of that. It is just, I'll put it against her pants, that's just astonishing. I haven't seen a presentation like this before. Really remarkable. And I have a little device. It's a machinist tool for measuring. And when I apply this at the mid joint, which is a tall pubic structure, so we're approximately mid joint, and so I'm pushing So what I see when I place that, it exceeds a centimeter. Remarkable. When I put my fifth metacarpal right where the fibrocartilage is between the pubic joints, and I attempt to spring it, it actually is hard. Okay? I thought that we might perceive extra motion there, but that's not the case. It probably has considerable tension going through it. If I push on each pubic bone, she's a little tender, so I'm not able to really do an accurate movement assessment. But with respect to the pelvis, I can load the pelvis and then put a little bit of force. There's a little bit of rotation, but not much, a lot less than we would expect. This is why. Would you line your stomach, please? Her sacrum is wedged posteriorly. Therefore, her SI joints are very stable. And this is the PSISs. My thumbs are on the PSISs. And you can see the midline of the sacrum at S2 is posterior in relationship to the PSIS. If I try and put some spring through that, there's no motion. At S1, nothing. L5, nothing. L4, yes. We start to get movement at L4. Okay? She does have, on the ilium, a little bit of anterior rotation give, but it's just a slight yield. Okay? She does have some vertical mobility. I can take up the slack, impart a little extra force, and the force travels through what feels to be a fairly normative manner, except that it's less than we would predict. The ischia, if we try and spring them, there's no give. No give on this ischia. The sacrotuberous ligament is rock hard. Okay? Well, this is supposed to yield, but there's no yield. It feels like a bone. So basically, what we have, to the best of my understanding, is a hypermobile or unstable pubic structure, and you would then predict an unstable SI at both sides, both SI joints. However, because the sacrum is wedged posteriorly, then that wedges the SI on both sides, so that's how she establishes stability. Okay? Ultimately, the treatment that we want to do to optimize her function is to restore motion in both SIs by moving the sacrum forward, using a small amount of force for a very long time, on the order of 10 minutes, to get that sacrum to move anteriorly and get both ilia to come posteriorly. Then we will do a similar length of time to move the pubic bones forward and outward so that they will tension that pubic structure and bring him more anterior. So we do want to soften the sacrotuberous ligaments, restore normative mobility and normative stability. If accomplishing the above, we come to realize that the pube joint is hypermobile or even unstable, then what you do is use an SI belt worn very low at the trochanters. And there is a surgical procedure for that. She was headed towards a SI fusion, and she was given a diagnosis of a right upslip with a right posterior ilium and a relative left anterior ilium. And that simply is not true. Based on mobility tests, that is not what the diagnosis is, and that's not, in my opinion, it's not the most appropriate treatment for her presentation. It's a different way of evaluating the structure, so there are different schools of thought, and I'm simply presenting mine. Okay? So I think we can stop filming here, and we'll come back and we'll do a post